I'm just waiting for confirmation. Yeah, hello everyone. Good afternoon, good evening, and depending on where you are, good morning. It's our pleasure to welcome you to today's session. We are trying to upload Professor Achim Sklerov's presentation, and so I just ask for a bit of patience, then we can continue. So we should be able to start in another 3 minutes. Okay, so Okay, is everything okay now? Okay, so I can start. I'm just waiting for feedback from the backdrop. Okay, thank you very much. And good evening, good afternoon, everyone, and welcome to today's session. It's been our pleasure to have you for the last 2 days, and now we proceed on day 3. And it's my pleasure to introduce, so my name is Patricia Korir. I'm a scientific coordinator at G-WAC, and I work at the University Hospital Bonn. I will now introduce our first speaker, who's Professor Achim Hörrauf. Professor Achim Hörrauf is a professor of medical parasitology at the University of Bonn, the medical faculty at the University Hospital Bonn. He's the director of the Institute of Medical Microbiology, Immunology, and Parasitology at the University Hospital, and the chairman of the German Network Against Neglected Tropical Disease, the DNTDs. He also is a member of the World Health Organization Expert Advisory Panel on Parasitic Diseases. And he is part of the G-WAC as one of the directors, and we really are excited to hear his presentation on diseases, emergence and reemergence, environmental and social cultural dimensions, and in an aspect of NTDs. After his presentation, we will have the presentation from Professor Alexander Debra. Professor Alexander Debra is Professor of Parasitology and Global Health at the Kwame Nkrumah University of Science and Technology. He is a member of the G-WAC Steering Committee and also a research leader for onchocerciasis and filariasis at the Kumasi Center for Research. So it's a pleasure to invite both of you today, Professor Achim Hörrauf and Professor Alex Debra. And both of them have been working together for more than 25 years in their research, and they will share. So they are research buddies. And so it's my pleasure. So Professor Achim Hörrauf, I leave the stage for you. Thank you. Or just please remember to put your questions in the comments and we will discuss them later. Thank you.
Yeah, thank you very much, Patricia, for the introduction, and thanks to the team to provide last-minute help to the presentation of the slides. This caused a little bit of delay, for which I want to apologize on behalf of our teams, but just a question from my side to everyone who can answer. Can the slides be seen? And can I be heard?
Not see the slides.
Yeah, can you see?
Not yet.
Okay, so I can be understood. So apparently, since the moderator cannot see the slides, maybe the audience cannot see them either, which would. So you can. Dr. Owusus tells me they can see me, and can you also see the slides? I mean, you know me already, but you wanna see the slides. Okay, so apparently yes. So then I just start, and in case something is wrong, then just interrupt and go in by audio. Yeah, as in the program, our task from my colleague Professor Debra and myself is to talk about disease fluctuations, disease emergence and re-emergence, also environmental and social cultural dimensions. And I added that because Professor Debra and I have a long-standing work on NTD, so neglected tropical disease, for those who don't know the term. And you may ask yourself, okay, this is a Center for Global Health and Pandemic Prevention, so what do NTDs there? And I think one of my ideas for this lecture is to make it clear to everybody that NTD work actually on the ground, in the periphery, where some weird things like a new pandemic or a new epidemic may start, is very helpful for health systems resilience in order to really have the enough knowledge on the ground to pick up those things quickly and bring them to the attention of experts in the bigger cities at the universities. And this is something that G-WAC stands out to develop and implement over the years of our funding. So next slide, please. So maybe you have seen that already yesterday or on Monday. This is a very busy slide. It essentially tells in the middle there's pandemic preparedness, and this is also not only pandemics like Corona. I think you'd also have to think of silent pandemics like antimicrobial resistance. All this needs some preparations from multiple angles. And of course, there are One Health aspect like wild habitat encroachment, virus mutations, wildlife trade, and so on, land degradation, but also neglected tropical diseases, because there are teams usually by national governmental entity programs that deal with them in a similar way as national programs deal with mother-child health or malaria or HIV problems. And this brings about a lot of capacity that actually is present in the periphery, aided and complemented by teams from universities, bigger cities. And they all try and need to be coordinated to really pick up everything that could go wrong in the periphery. Therefore, work on NTDs is quite a good litmus test also for the resilience of a health system. Next slide, please. So for those who are not so familiar with NTDs, but this is a major part of the work within G-WAC. I just put up this slide to, you can see it on websites of WHO and elsewhere, what is actually the portfolio of neglected tropical diseases. And this is a term that is about 20 years old, when specialists of tropical medicine realized that there is a lot of diseases other than malaria, HIV, and tuberculosis that need attention by local governments in order for the people to become less burdened with disease and therefore exit a vicious cycle of disease, not being able to work, poverty creating disease again. So you all know that. And to get out of that, you need really to start where these diseases are most prevalent. And this is the rural and poor areas that are usually neglected as governments develop their states. They start with the big city, the affluent lives, but there are rural areas that keep being neglected, and this needs to change. Next slide. So WHO has also invested a lot of thought how best to control these diseases, because there's more than 1 billion of people affected. And of course, there are one major driver, as just said, is poverty. And the medical conditions originating, underlying NTDs very often are not only the disease of the humans, but inadequate sanitation, so you can do something by more hygiene, or it's a zoonosis brought about by livestock or domestic animals or wild animals, and there's just an overspill to humans. So the major intervention needs to be by the veterinary. And you may have already heard when you were told how G-WAC is organized, that at the KNUST, there are several faculties, among them not only medicine, but public health, laboratory health, so allied sciences, and also veterinary. That is part of our consortium. And this is because we cannot just look at medical conditions in humans. We need also to go beyond and include that in the best sense of a One Health approach. So there are some diseases that can actually be quite well prevented by chemotherapy, by so-called mass drug administration. And this is something that some of you who have already dealt with, for example, tropical helminths like filariasis, bilharziosis, or soil-transmitted helminths, that there are programs, for example, for schooled children or for just the whole population eligible for yearly once or twice mass drug treatment that brings down the level of parasitic infection and tries to control the transmission and ongoing disease. Next slide. There's a common denominators of neglected tropical diseases, as the name says, where there is neglect. Usually, the gross domestic product in terms of income for the population is rather low, and not surprisingly, the countries that have the lowest GDP per capita in the lower graph are the ones with the highest burden of NTDs. So you can see Ghana is one of the light blues, for example, where there has been already a tremendous success in reducing the NTD burden, and this comes in parallel with an increase of the GDP in this country. Next slide. So as said, there is a huge lot of people still in need of cure or at least control, and control can be rather cheap. So if you see the last sentence down there, there says 50 cents can fund treatment. That is meant fund treatment per person against the 5 most common NTDs, which is the ones I already told: bilharziosis, filariasis, soil-transmitted helminths, and trachoma, for example, and they are all chemo preventable. So there is a lot still to do, and what we have done is we have accompanied and aligned with national health programs, national NTD programs, to close gaps that have been in the system because of lack of funding and because of lack of attention. Because we are researchers, we try to open up identification of new gaps and close them together with our global colleagues in global health. And this is why we are here together. And of course, this comes then with increased capacity building, both of academic sector, but also of volunteers in the communities on the ground. Next slide. So the WHO has set up a roadmap because of initial success with control of the NTDs. And this roadmap covers this decade from 21 to 2030. And there are quantitative targets like the ones you can see here. So 90% reduction of people requiring interventions. 75% reduction in disability-adjusted life years. 100 is the number of countries being where having eliminated at least 1 neglected tropical diseases and 2 neglected tropical diseases to be eradicated. So this means globally eliminated altogether. So there are ambitious goals, and if they are not reached, then at least they can be reached in part. So, for example, if 80% of the population does not require interventions, this is a very good success. It's not a non-success or a failure, but even if 90% is not fully reached, we can be happy and satisfied with the achievements. And we all know that global events like a pandemic, like Corona, or wars, and not only civil wars, but wars of larger extents, will of course slow down all the progress because it usually leads to a cut of funding and awareness. Next slide. So there have been already previous roadmaps of the WHO to control NTDs, but this one is novel in several respects. So one is measuring progress. I just told you that there is a measurable figure, like 90% of the population not requiring interventions. So you have to measure where you actually are. You have to make scorecards and then see how much you succeeded against your plans, your ambitions. This is one thing that is new. So even if you don't fully reach your goal, you at least reach it partially. Then the program aims at integration. So national programs, they can just distribute more than 1 tablet intervention. So for example, if they treat for lymphatic filariasis in Ghana, they distribute ivermectin and albendazole. Albendazole is also active against the soil-transmitted helminths, so you can cover this program with the same drug. And if you organize it well, you can do it with the same team, and you don't have to double your efforts, but you can really save on the efforts on manpower, time, and money. And this third one, which is very important, is the support by the endemic country, by the own country. So it's called country ownership. This sounds nice, but it comes with a responsibility that for those activities that the WHO does not fund or not coordinate with funding, like drug donations, the endemic countries have to come up through their health systems. And here we are again by resilient health systems, capacity building, making the health system strong so that it is strong enough to do the jobs, for example, here for NTDs, but also because there's enough trained personnel, it would pick up a new pandemic more quickly. This is how these two fields, NTD and pandemics, are linked together. Next slide. So the WHO is not standing alone. There's a lot of non-governmental organizations and other big funders. Talk about the Gates Foundation, talk about big Arab foundations, Aga Khan and others that help a lot of countries implement the programs. And they all came together last year for a follow-up summit to the 2012 London Declaration for Help Against NTDs. Now, this new one is called the Kigali Summit. Why in Kigali? In Kigali, because this was an event where all Commonwealth's heads of state met to look into diseases, mainly to malaria, but they also gave a few hours on NTDs. And they had a big program of to welcome and endorse. Next slide. Of course, there were important people and major donors. WHO represented, President of Rwanda in the middle, now King Charles, at that time Prince Charles, as the principal of the Commonwealth administration, Melinda Gates, and many other important people were here to welcome the endorsement of many other participants. And the endorsement is huge. Next slide. It says that there is 1.5 billion financial value and 18 billion tablets committed in order to achieve these goals that you already have seen on the WHO slide with the reductions that I already told you. Next slide. So Kigali is there to help and bring in other stakeholders. Now, going back to the last part of this new way how the WHO does the roadmap, country ownership. Next slide. It means that you have to set up in an endemic country also some programs that are not covered by Kigali, not covered by the sort of addressed by the WHO roadmap. For example, disease sequelae control, but it's not covered by any funding. So the health system, the national health system, has somehow to come up. And why is this a must? It's because the UN has developed the Sustainable Development Goals that you see here. There's 18 goals with a number of sub-goals. And for us, an important one is health, which is SDG number 3. And SDG number 3.8 is called Universal Health Coverage. And what it means, it sounds trivial. Yeah? Everybody should get his or her health covered, but it means that there should be no out-of-pocket payments for entities. So if you, for example, suffer from filariasis and you have a hydrocele, and you have no money to get an operation for your hydrocele, you shouldn't have to pay yourself. There should be a health system in place that covers this for you, for example. And this is where Professor Debra and I, over the last years, also developed programs that are part research, part implementation, in order to improve the situation for our main group of diseases, which is the filarial infections, and here mainly lymphatic filariasis. Next slide. Can jump over that. Yeah, so it means a lot, meaning to reach really to the periphery on the ground You know all that better than I do. It's really where people start not being so willing to go and do medicine. So some people have to do it in their social year after study. But the tendency to go back from rural areas is, as you know, rather big. But here is where we need to get the preparedness for the next pandemias, and also for antimicrobial resistance and a lot more. Next slide. Yeah, so the disease sequelae, as I already said, in lymphatic filariasis, for example, on the left slide, hydrocele, genital enlargement because the lymphatics are destroyed because of inflammation that are set by the worms. And the other is inflammation of the lymphatics of the extremities, mainly the legs, leading to elephantiasis. Next slide. And we have millions of people suffering from that. And even if, next slide, please, and even if by mass drug administration, the transmission of filariasis infection should one day be fully controlled, these people would not stay healthy or would not become healthy all of a sudden, because the disease sequelae are already independent from the infection. So what you have to do here is some basic treatment, like hygiene treatment, as shown here on the slide, or tablets against acute attacks, feverish attacks, or maybe even a drug that we propagated. It's doxycycline, because it seems to help early stages of lymphedema development. Next slide. I think it's on the next one. Yeah. And so the German Ministry of Education and Research has actually funded a partnership between Germany and Ghana, but also including two other African partners, colleagues from Cameroon and Tanzania, in order to deal with lymphedema of filarial origin, and in Cameroon of poroconiosis. This is a condition when you walk barefoot on volcanic soil with silica in the soil, then you may develop also a lymphedema, which is non-infectious but due to silica. And we wanted to really do something and show the communities that a stringent hygiene plan plus or plus minus some antibiotics may be able to really improve the situation. Next slide. So we could show in the past that early lymphedemas, you can see this slide in the middle, a lymphedema that is classified according to the lymphedema scale in 7 steps. So it's stage 3, where you already see some folds in the ankle. So it's a starting lymphedema, but you can reverse it by hygiene, aided by doxycycline. If you administer very stringent hygiene, you may not even need doxycycline, as recent research from this team found out. But at least you can do something until this stage, definitely. If it's more progressed, you may come too late, but this can be done, and this needs to be done, and people should rely on the help by the national health systems in order to improve their conditions. This is the message that you should take home. Next slide. Yeah, so these were, we even did try, we did not just do implementation and bring hygiene and drugs to the people, but we also measured them. And we did that together also with colleagues that were not funded by the Germans, but by the US, by USAID. So altogether, there were 6 trials dealing with that. And we are yet to publish the results, but it really says if you apply stringent hygiene, you can bring back a stage 3 lymphedema down to the very beginning. And this is a very good news for all people affected. But you have to really work on that every day with hygiene. Or if you can't do that, you take doxycycline once a year in a cycle of 6 weeks. Next slide. Yeah, so I think we jump over 1 or 2. So the order has been upside down. Go on. One more. Yeah. And part of this activity in this network called Takeoff is also that we realized that the people with disease sequelae, they are actually not really captured by the database of the national programs. there is a gross underreporting. 90% of cases almost do not go reported. That's something we felt because we first tried to get the files of the National NTD program in order to identify the people in need. And there were very few data. And we realized we had to go to the communities and find the people actively. Or then what Alex Debra and his team did with Dr. Linda Batzer in particular, they developed a mobile phone-based system. And I think Alex is talking about that maybe in a bit more detail, but I just touch it here because it was really, really amazing how many more cases we got. And this is a system that is even workable by an illiterate community health volunteers because it's a interactive voice response. So IVR stands for interactive voice response system. Like if you are in the waiting line for your telephone company and they tell you if you have a question to your telephone contract, press 1. If you have another question, press 2. So the same type of algorithm leads you here through the whole system and makes you enter data about the patients, male, female, stage of lymphedema, years of duration, and so on. So what you do get, if you put that on a server, and the system allowed that, and it actually, the project paid for the telephone call, so the health volunteer in the village didn't have to pay anything. So we got the data via mobile phone, and they were really several-fold higher in the numbers of people in a certain district that were in need and that allowed us to come by and implement the treatment. Next slide. This is basically shown on that graph. So if you take what was done on paper files, what was done by the files that were taken during the times of mass drug administration. That's what the Ghana Health Service can do because they only do mass drug administration. Many people did not show up with lymphedema. So if we really actively sought the cases, you see the orange bars, this is much more. And therefore we could really prove, and this is published, that this improved the situation very much. And we now collaborate with the Ghana Health Service and national programs that these data be implemented in their databases. So as a facilitation to get a better database for their future interventions that Ghana has to do and hold for these patients. Next slide. Yeah, so as I said, so we the activities towards capacity building as a cornerstone for a resilient health system are on several levels. They are community workers training and helping by necessary tools like mobile phones and programs. And then, of course, the academics is starting with PhD training programs, something that you are experiencing at the moment, online courses for certifications, exchange programs, of course, research as well. And on top, there is international networking. So G-WAC is part of a bigger network of African network, for example, against neglected tropical diseases, where Dr. Amwasi is the head, and many others that come together to make most out of funders' money in order to improve the situation. Now I may have to jump back a few slides, but let's just take the next one. Maybe there is one. Yeah, this is what I already said. Very similarly to new viruses sweeping across the country or across the globe, there is a much more silent pandemic, and this is antimicrobial resistance. And you know that resistance comes by many means. One is wrong use of antibiotics or too much use, unnecessary use, but also, of course, antibiotics in agriculture, in animal raising, and poor infection control, poor other sorts of hygienics, or lack of specific diagnostics, so overuse of antibiotics where it's not used. And of course, it may spread from different sites, and it is not such a spectacular killer as, for example, the coronavirus is, but it is in quantitative numbers at least as much a killer. Due to bacterial infections that could in principle be avoided if we had the right antibiotic and if we didn't experience so much resistance, there is millions of deaths that can be prevented every year globally, and we have to do something. And I think this is the next step where health systems and infectious diseases also need to get to, and this is why G-WAC also endorsed it as part of its scientific activities, that we need to tackle antimicrobial resistance. So all the students that want to join G-WAC for future PhD programs should know that we are also tackling this one. Now I think I have to go back a few slides to the ones I left out. Sorry for that. Let's go back. Yes, further. One more. Yeah, so G-WAC did not sort of fall from heaven, but there was, of course, also a lot of track record from many sides. You see down there the Berlin institutions. I have already mentioned the African Network for NTDs of Dr. Amwasi, but Professor Deborah and I can also look back to, as Dr. Correa has already said, more than 20 years of collaboration with several funders. And that finally led to the fact that our two universities, Bonn and KNUST, signed a memorandum of understanding. The photos are down there. And that helped bring about an Erasmus student exchange program that some students have already enjoyed. Plus, now I think it was an important cornerstone for the application of G-WAC. So you need to puzzle together your activities through several projects in order to do what we want to do: capacity building, health resilience, of course, in parallel to good research. Next slide. And what I in particular find interesting, and maybe Professor Deborah will talk a little bit on that, is that we always talk about of either community health workers, or on the other end of the spectrum, the academics, the PhD students and the young professors and so on. Is both necessary, but what we also need is actually a nursing program. We need to raise the level of education, and this is being done, of course, now at the nursing level. This is done at KNUST, because the graduates from these courses, they will actually be in the periphery much more than the medical doctors. And if they have been well trained and can be alerted to AMR, to NTDs going wrong, things going wrong at HIV, or also new pandemics, then I think you have strengthened the health system considerably. This is why why we put that also as a very important cornerstone of the activities that laid the ground for G-WAC. Next slide. Yeah, you see it here. So there are these activities, and of course, this is always a ping pong type of event. Once you have a good program, you get new collaborations, and you can secure the funding to really keep the program sustained. Next slide. Now we can jump over these. I have already shown you. Next. Yeah. So that also leads, of course, activities in the periphery means that people are being trained in the field to be able to diagnose NTDs. That's what we are doing, but we also train local people in regional hospitals, for example, in microscopic evaluations, in clinical examinations, and so on. So we improve the knowledge of the staff, and I think this is something that we want to continue through G-WAC. Next slide. And of course, you need some amount of funding of also bring the laboratory work on a level, for example, one that allowed doing PCR in the corona pandemic. We can also do that for other diseases now. We have sample storage capacity. And at the same time, of course, these labs offer perfect opportunities for interested and good students who want to do a good PhD in the lab. Next slide. Yeah, so but this is not as it may sound on first sight always due to international projects. So I really realized with a big joy, and this is the photograph on the left side down there. Professor Deborah and I are standing in front of the new building of the Allied Health Sciences. It's a huge building, and on the right-hand side you see the German ambassador actually cutting the entrance open to these new buildings, where one wing will be reserved or has been reserved for the G-WAC activities. I think this is really as much necessary as what we said before, that for SDGs there has to be investment by the endemic country in fighting disease sequelae, which is not covered. There has also to be investment on the academic sector. And of course, this is something where you all can be proud of, that your university is really going to expand and making these important things happen. It's not possible if there is no money from home also coming into the system. Otherwise, it will definitely not be sustained. So be congratulated on that. Next slide. Yeah, so our part in Germany is, of course, to act on different levels with political stakeholders. So not only the Prime Minister, who is now, of course, no longer active, but also parliamentarians, is the second slide, who we regularly inform about the activities on NTDs and on pandemia. And we have a parliamentary advisory board in the left slide down there in the German parliament that is part of the global health group within the parliament, international health and global health, and they deal with that. And be assured that they know that the German parliament needs to set aside, even with tough financial challenges otherwise, enough money in order to keep our collaboration ongoing, so that we don't lose the achievements that we have brought about over the last couple of years or decades. Next slide. Yeah, and if I have the chance, I even had once the chance to tell your president about G-WAC and why it is so important to fund academic capacity building and non-academic capacity building for the health systems resilience. And it was a very nice scientific interaction, although it was only for 5 minutes when he was about to go. But anyway, it's good to reinforce at all levels. And with this, I think I'm done. Let me see. Last slide. Yeah, this is just to bring it into context with all the active stakeholders within within G-WAC. And the slide is from our launch meeting last year. So I'm happy to answer questions if there are any, and hope you can take something home from this lecture. Thank you.
Yes, thank you very much, Professor Herr. And it's really good. It's a very nice lecture, and really enjoyed it. And right now we proceed first to the lecture from Professor Alex Deborah, and then we will do a combined discussion and take questions. Professor Deborah will present on risk communication and public engagement. Prof, the floor is yours.
Thank you very much, Dr. Corey and Professor Akimero. Thank you for that brilliant presentation. So you can see from my background that you can see some hydrocele and then onco patients, confirming that yes, I've been working with Akim for the past 20 years. So this afternoon, I've been asked to actually talk about risk communication and public engagement. For the past 3 days, we've been hearing of One Health concept, we've been hearing of pandemic preparedness. So we are going to look at how risk communication and public engagement is also involved in One Health system and pandemic preparedness. So my line of presentation will be, the outline of the presentation will be first, what is risk communication and community engagement, which normally is Christian RCCE, the importance and the principles of RCCE, the types of risk communication, the different goals of risk communication, And what are some of the barriers of risk communication, key factors for successful RCCE, and finally, we will summarize and then conclude. So the question that has been asked is, what is risk communication and community engagement or public engagement? Normally, risk communication and community engagement, which is a pillar in public health emergency responses that ensures accurate health information sharing. It is also for adoption of protective barriers by affected people and collaborative participation by all stakeholders, including the local community structures. Here we mean all stakeholders, right from the top, from the government officials up to the last person in the community. RCC has existed for some time, but it became prominent during the last early of COVID-19 pandemic, when WHO realized that different countries were doing different things, haphazardly, not coordinated. So WHO actually came back and said, they included, as part of national health public emergency responses, so what is risk communication? It is defined as the real-time exchange of information, advice, opinions, people expect opinion between expert or officials and people who face a threat to their survival, health, economic, or social well-being. Here we mean experts. The communication or the information doesn't have to come from anybody. It has to come from experts and officials who are mandated to actually communicate. Normally, when there is pandemic or emergency, you see all kinds of people going on air, giving advice, giving information, which most of them are not, correct. Here, the information must come from expert and official people. The threat could be an outbreak of a disease, epidemic, pandemic, flood, earthquake, etc. So when we say, emergency or threat, here is not only just pandemic. It could be an outbreak of a disease like cholera, Ebola. It could be flood. Like recently there was earthquake in, Syria and Turkey, which could actually lead to emergency. So all this combined is called the threat. The purpose of risk communication is to ensure that everyone at risk for a disease is informed about how to reduce the risk of spreading the disease, and also to take personal protective and preventive measures to stop the spread of the disease. Normally, public health officials must report fully and rapidly what they know about the disease, about the outbreak, what they suspect, and what they are doing to control the outbreak. This must be communicated to the people. And communication with the public during an outbreak is normally critical, not only for rapid control of the outbreak, but also to keep the public informed and reduce the risk of social, political, and economic agitation. Normally, if there is an emergency, if there is a threat, if there's an outbreak, the people become agitated. There is the need to communicate, to the people so that they can be calmed down. It also helps to ensure exchange of accurate information among healthcare workers and authorities, and also between healthcare workers and the population at risk. Now, what are the aims of risk communication? Why is risk communication important? Normally, it's supposed to achieve improvement in the knowledge and understanding of disease or an emergency. This involves spread of, the mode of spread of the disease. The people must know how the disease is spread so that they can prevent themselves from contracting the disease. They must know the signs and symptoms of the disease so that if they have symptoms or if somebody or a neighbor has the symptoms, they can know and report. And also, it involves preventive and treatment measures and also adoption of appropriate protective and treatment behaviors. So when we see community engagement, what does it mean? It just means you engaging the community, you engaging the people at the local level. It is normally a process of including at risk and affected communities in outbreak control response throughout the process. Here it spans from planning through surveillance up to implementation and monitoring, and it's supposed to promote and facilitate community ownership in the response that we are talking of. So community engagement actually proceeds through in-depth interpersonal outreach and dialogue to plan local solutions that are specific to a community needs. This can take many forms. It can be a face-to-face with the people in their own community. It can be through local radio station, FM station, television stations. It can also be through social media. Normally, outcomes of effective community engagement are about community ownership of the response, and this includes increasing trust of the people, confidence, cooperation with response teams, community feedback, and finally, uptake of preventive practices. So the question that is normally asked is RCC, that's risk communication and community engagement, really important? Normally, when you read papers or you read articles or you hear, on air people arguing whether risk communication and community engagement is important, this is because they think so much is spent on RCC and what is important. Is it worth it? Normally, RCC is often considered the least important of public health emergency response pillars. However, it is the key in breaking the chain of infection during a disease outbreak. And RCC is also important during emergency response in promoting non-pharmaceutical interventions to interrupt disease transmission in the face of delayed medicine of vaccine development process, as we saw during the COVID-19 or during the Ebola outbreak, when there was no medicine for treatment, when there was no vaccine for protection. Actually, the entire world depended on RCC for for stopping the spread of the disease, which actually worked perfectly. So what are the goals to risk communication? According to Kasper and Tar in 1992, they actually defined 5 goals of risk to communication. First, they said you must diagnose and create trust among the people. You must create awareness strategies. You must understand why concepts are hard to actually grasp. And you must find a solution to overcome these problems. And you must actually develop mediating skills to contain the risk. And finally, you must motivate the public, the grassroots, to actually act. So there are 5 basic principles of risk communication. The first one is to identify the risk. The most important thing is to identify the risk. If there's an emergency, there's the need to identify the risk. For instance, again, going back to Syria and Turkey, when they were there, they have no food, they have no water, they have no basic things. Actually, experts came out to actually predict that there will be a cholera. And indeed, we've heard that there has been an outbreak or there are some cases of cholera, in Syria. So the first thing to do is actually to identify the risk and then go ahead to assess the impact of the risk. And after assessing the impact, what do? You try to implement mitigation processes to actually contain the risk. And then you also need to monitor the effectiveness of the communication you are putting out there. And finally, you need to report on the effectiveness of your communication effort when the crisis is over. You also need effective presentation strategies to actually communicate your message. But before you do that, you need to actually identify stakeholders involved. Who are the stakeholders? And what are their concerns? You need to actually see their concerns and also understand the concerns of the ordinary people out there. You also need to develop key and simple messages that the people will understand, not actually jargons. And then you need to also test the messages if they are appropriate and effective. There was a situation when during the COVID-19, we saw different adverts, on television, adverts portraying a rich man, taking some red wine and advising the people to stay home to actually take wine. And when you look at the population, many people, were below the poverty level. So if you take a rich man enjoying his wine and say stay home, how many people will actually take this message seriously? So we need to actually test it if it is appropriate and effective. And after testing the appropriateness, we also need to plan how to deliver the messages. And finally, to also develop supporting information. Normally, there are some factors which affect the impact of RCC. What are these factors? It is known that 3 main factors actually affect affect the impact of RCC. The first one is the audience that you are talking to. The second one is the content of the message you are telling them. And the third one is the source of the message, whether the message is trustworthy or not. Normally, the audio perception is actually influenced by demographic factors such as age. Normally, the young ones may not, bother too much because they think they are, the disease is not affecting them. We saw it during the COVID, outbreak where the young ones thought, is a disease of the old people. Gender may also affect the perception of the people. Personal profile. People think because they can afford everything, they don't bother. And then sometimes it's from past experience and also from ideological orientation. So when it comes to types of risk, actually, Peter Sadman, he classified all types of risks into 4. He christened them: 1, public relations; 2, stakeholders relations; 3, outreach management; and then 4, crisis management, which you will see very soon. So when we take the first one, which is the public relations, here the hazard is very high and the outreach is very low. Normally, the audience involved in this kind of risk communication are apathetic. They don't show any interest. They are inattentive when you are talking to them. They don't bother. They are not interested. They don't talk back about what you are saying, but they are just not interested in what you are saying. When you meet such people, what do? What will be your task? Normally, your task is actually to produce brief messages which will send the information straight to them. That will reinforce whatever appears, are mostly likely to predispose your audience towards your goal. So here the message should be short, precise, and concise. And normally, what kind of medium do you have to use when you meet such people? You normally use monologue, via the mass media, sending out information, giving them education so that the apathy will actually be removed. So in terms of public relations, what are some of the barriers? The barriers are audience inattention. The audience will not listen to you. There was a situation where you go to the communities, you want to talk to them, they will come and listen, but they won't ask you any question. They don't care. When you leave, they also leave. So this could be a barrier, audience inattention. The audience size can also be a barrier. And then sometimes there could be media resistance because they don't listen to what you are saying. And there is the need to package everything into short sound bites. In this way, what is the advantage of the silver lining here? Here, there is little need to listen or to address the audience concern because they don't have any concern. They will just not listen. But they don't have any concerns. They don't have any reservations. They don't have any objection to what you are saying. This, they normally have a few or no reservation to what you are saying. Then the second risk relation is the stakeholders relations. Here the hazard is medium and the outreach is also medium. Normally for such audience, they are interested and attentive. They are ready to listen to you, ask you any questions because they are interested. They will never, be bothered. They do not accept to listen. And then the ideal audience, these are the ideal audience because they will listen to you. They want to listen to whatever you are saying. They will ask you all kinds of questions and they want to understand whatever you are telling them. In this case, what will be your task? For stakeholder relations, you need to discuss the issues openly and rationally with the people, explaining your views, you are responding to audience questions and concern. Here, the medium mostly used is dialogue in person, which is normally supplemented by specialized media, website, newsletter, etc. Are there barriers in this? Normally, the barriers are few, if any. This is because the people are ready to listen to you and they will ask you, questions to understand. Here, the barrier will be you have to be prepared to explain technical details because they are interested. They are intelligent. They will ask technical questions, so you might be ready to actually answer their questions. Is there a silver lining here? Yes, this is the easier communication environment because the people are interested, they are attentive, they want to listen to you, so you can send out your communication. Ideally, duplicating this is the goal of the other 3 kinds of risk communication that I'm going to talk about. And then we have outreach management. Here, the hazard is low, but the outreach is high. The people are outraged. Before you go to the community, they are already outraged. Normally, in such communities, there are a few people who make themselves champions. They've made up their mind before you even went there. So once you start talking, they won't listen to you because they are outraged already, either from their past experience or whatever. Here, what will be your task? Your task will be to reduce audience outrage by listening to them. You have to listen to them. You have to acknowledge what they are saying. And sometimes, if it's from past experience, you need to apologize. It might not be you, but it might be another official person who did something that they did not like. So if you have to apologize, in order to calm them down, you have to apologize. The controversy actually ends when these fanatics declare victory, or their constituency or their people think they have won enough. In this case, what should be the mode of communication? It should be in person. You get one or two of them who are actually not ready to listen to you. You sit them down, talk to them one-on-one, and then by so doing, sometimes they will listen to you. Are there any barriers? The barriers here is that the audience are outraged. They are annoyed with you, and you yourself, you are disappointed. So your own outrage at the audience is also there. And coming to grips with the need to focus on outrage when you should have rather talk about substance. So here the barrier is that people are annoyed with you, and you also are annoyed with them, and even annoyed with yourself. Is there any silver lining? At least you have their attention because they want to listen and maybe cause trouble. They will listen to you, so you have their attention, all right, though they may be hostile to you. So the last risk communication is the crisis communication. Here the hazard is high, and then the outreach is high. Here the outreach is huge and upset. In the crisis, the outreach is mostly fear and misery rather than the anger. If either is unbearable, it may flip into denial or escalate, and this may lead to disaster and then depression. So what will be your task here? Here, you try to help the audience bear their fear and misery. And the key strategies include avoiding over-assurance, and then sharing dilemmas, being human and empathic. You have to be empathic, providing things, to do, and then acknowledging some uncertainties. What should be the medium here? It's normally monologue via mass media, and then dialogue in person to actually extend, to that extent. There is no public, crisis in this. What are the barriers in this? The stress of the crisis itself is a barrier, missing the difference between the crisis communication and the routine public relations. Is there any silver lining here? Though outrage is very high, it is not directed at you. At least you know that the audience are not, annoyed with you. Any anger at you is put aside until the crisis is, passed. So these are the four main risk communication. So what should be the content of your message? The message should be simple and clear. That will prevent the spread of the threats. This can include, for instance, during the COVID outbreak, personal hygiene, such as hand washing, mask wearing, stay home while sick to avoid the spread of the illness, and then physical and social distance. These are simple that people can easily do before when there is medicine or vaccine you introduce. So the message should be simple, clear, understandable, and everybody should be able to understand. And as I said earlier, we need to avoid jargons. And then if there's medication, you actually encourage the people to take medication. And if there's vaccine like COVID-19, you actually encourage the people. You go to them and encourage them to actually take the vaccine. So the WHO has 5 communication principles. The first one is trust. The source of the information must be trusted so that the people can trust what you are saying. There should be transparency. The announcement should be early. We shouldn't delay. If there is outbreak, if there is emergency, and then you delay the announcement, people become agitated. And this is where they start to actually agitate, which could lead to political agitation and other agitation. And you need to listen to the people, and then you need to plan actually with them. What are the barriers to risk communication? There are social factors that can make risk communication more difficult. This includes language differences. Yes, in places like Africa, where in a country like Ghana may have about 7 main languages, about over 100 dialects, then risk communication becomes a problem, because when you move to any community, you need to understand the language, or you need to get somebody to interpret your message for you. Cultural factors may also come in. Some people will tell you, for this message that you are talking of, in my culture, we don't do that. And then religious laws and fanaticism may also actually be a barrier to risk communication. Illiteracy, as we know, is a big problem. Poverty, the people may be ready to actually stay home, but when they stay home, what are they going to eat? So because of that, it becomes a barrier. And then sometimes lack of legal and technical and policy resources can also be a barrier. And finally, lack of structures that support communication can also be a barrier. But when you go to nowadays, Ghana is better, but when you go to some countries, African countries, there are no local, radio stations, there are no television. So if you don't go down to the people, actually, there will not be any medium to carry your message across. So who is responsible for risk communication? All stakeholders are involved, starting from the government, from governmental institutions, from agencies, institutions, industry, media. Here we mean both social and traditional, media should be involved. And then the consumers, the community members, they all have roles and responsibility to guarantee effective risk assessment and risk management. So there are 4 pillars of risk communication. These are supervision, monitoring and control, interventions and treatment, and victim safety planning. So what are the key considerations for successful RCCE programs? There are 4 main keys. The first one is partnership and engagement. So when there's going to be a risk communication, what are the existing partners and their roles? When it comes to emergency and outbreak, you see that there are so many partners duplicating the same thing. Actually, it becomes ineffective. In fact, it becomes counterproductive. And how are these actively engaging together, including the role of the community? How do we bring in the community in this partnership? And then plans and guidelines. What plans do we have? What guidelines do we have? What strategies do we have? And what activities or plans are in place to actually support RCCE activities? And again, how are these implemented for impact? The planning, the objective, activities, monitoring, and evaluation. And then when it comes to reporting and documentation, what measures are in place to actually document the reports or RCCE at all levels by partners? How frequent do partners meet or engage with each other for information sharing? All these are important, to actually ensure the impact of RCCE. What are the identified gaps? And then what are the appropriate interventions that could be implemented? And then when it comes to coordination, is there an existing coordination structure that we can follow on, either from the national, from the regional to the community level? Is there organogram? Is there reporting structure? Is it bottom down, down bottom? How is information flow managed within the structures? Is it top bottom or bottom top? As I said, all these are very important, for risk management. So in conclusion, risk communication and public engagement is important in any threat or emergency management. The public should be engaged at the right time with the right message. The message should be simple and clear and must be convincing, and we must avoid jargons. There should be trust, transparency, announcements should be early. We should listen and then plan together with all stakeholders. All stakeholders must also be involved. So on that note, I'd like to thank you very much for your attention. Thank you.
Yes, thank you very much, Professor Deborah. That's a very good presentation. And we already have questions on the chat, and I would like also to welcome Professor Achim here so that we can have the discussions and continue. And yes. Okay, I will start with the first question that has been directed to you, Professor Ferov. And that is from Albert Agiopong, who asks, is the focus only on diseases of humans, or it captures zoonotic diseases? So what is the priority of NTDs?
Okay, so with the NTDs, I mean, basically they are human infections. I think to the NTDs at least in the WHO portfolio, if you wish, of 20 diseases, they are all human. But of course, not always human. There are a lot of zoonoses where the human disease is rather a spillover of cycles that go on, like pig tapeworm or leishmaniasis that go on in animals. So this it captures definitely zoonotic diseases too. Yeah. So you have leishmaniasis, you have pig tapeworm, you have Chagas, you have a lot of others that you can see down in this list. About 50% are also involve animals.
Yes, thank you. We go to the next question, and this is directed to you, Professor Deborah. And the question is RCC employed only in instances of infectious disease outbreak, or it can be employed in other scenarios?
Well, thank you. As I said at the beginning, anytime there is an emergency, RCC should be employed. They could be not only in infectious disease outbreak, but in other areas like, earthquake, flooding, any emergency, situation, RCC should be actually employed.
Okay, and then there's another question. That's what should one do in the event of non-compliance during risk communication? That's to you, Professor Deborah.
Yeah, this is a common thing that happens, during risk communication. Some people will not comply. It's just like even for the NTD that Professor Akimura talk of, where there is draft for, mass drug administration, people will not comply. In this case, you actually need a social scientist to find out why are the people not complying. Some people have genuine reasons. For instance, if you tell somebody to actually stay home, not go to work, and that person has nothing to eat, will that person comply? That person will not comply. Probably not because he doesn't want to comply, but he doesn't have the means to actually stay home. So people will not comply, but we need to actually know why they are not complying, and then to find mitigate measures to contain that.
Thank you. I will ask one more question to Professor. Okay, so we continue. That's back to you, Professor Deborah, and risk communication. How does one avoid coming off as being unlearned? Prof. Deborah?
So yeah, I'm reading the question. In expressing uncertainties in risk communication, how does one avoid coming off as being unlearned? Well, if I understand the question, I wish he could explain a bit what he means by, coming off as being unlearned.
Okay. I think we skip that and just proceed to the next question, and maybe we can get a clarification. But there are questions like of social media. So we saw like how social media was used, and that applies to both you, Professor Herhoff, and to you, Professor Deborah. So we start with Professor Herhoff. What's the importance of social media, and in a positive way, and how it's also negative in also communicating disease outbreaks and emergencies?
Yeah, I mean, it's a global phenomenon, and we have seen it throughout all countries in the corona pandemic with different facets of misinformation, or of people thought they were misinformed. and we still have a lot of discussion going on whether in Germany we did all things right and we could have done better and so on. You may remember that countries in Europe like Sweden took a relatively liberal stance with avoiding a lot of mask wearing and social isolation, and still they had more deaths initially, but at the end, after 2 or 3 years, the difference was not so much, really. Not so that we could say what we avoided by more stricter measures was the quick deaths in the population, but on the end, we did catch up, unfortunately. So anyway, so to come back to social media, just needed to say that the truth is really difficult, and I think we need to put in much more science to really understand a lot of that, what happened, and social science can, in the positive way, channel also dissenting views and bring about some corrective to the state-run media channels or private big media channels, because they may not always be representative of what people think. But it turned out, and we could really see that some really weird questions and assumptions would burn high, and people would get even threatened. So, for example, our well-known colleague Christian Drosten, who was a leader in the pandemic, he really got really bad social media critiques from some people, and then had to call for police and so on. So this is really something where I think the last words are not spoken, how to avoid that, Twitter then was quick to block those things, and allowed even also the people, of course, who were accused, to block these. I think we probably need to improve there as well. On the one end, to allow dissenting views, but really avoid the aggressive ones.
Thank you. Professor Deborah, what's your opinion on social media in risk communication?
Yes, this is a big problem, and it's real. We also saw that during the COVID-19 pandemic, where there were a lot of conspiracy theories, people were proposing all kinds of things, and this was actually circulated, on social media. In Ghana here, for instance, we had our share where, all kinds of conspiracy theories were proposed. This is where RCC actually has to come in to actually go to the people and educate. And I remember in Ghana, for instance, the president was actually vaccinated openly for people to know that there is no poison, or there is the vaccine be administered. It's not harmful. So yes, it's a problem out there, and I think this is where RCC can come in, go to the people, talk to them, educate them on radio, TV, just as our president did, where he was vaccinated openly. Asante Hene also did the same thing. And I remember I went to one community. I was actually going to work on a different disease, onchocerciasis. And because they saw KCCR and they know KCCR is the center where we were testing COVID, they said we were coming to actually test them for COVID. And my team was nearly chased out of the village. And I was called by the local radio station. I had to explain to them, and I even told them that day I had taken my shot, which is the vaccine, And then the following day when we went there, the people actually accepted it, because I took the opportunity to explain to them that the vaccine that they said is poisonous, it's not poisonous, and I myself had even taken it. So yes, this is where RCC actually has to come in to forestall the conspiracy theory.
Thank you. The next question is on what is it too much information? So when sharing information with populations, how much information is too much information? And how do you avoid generating panic while but still giving adequate information?
Yes, you must look at the audience you are talking to, and you must know what information to give at what time. If the information becomes too much, it may create a problem. So you have to be precise and concise, and there are situations where you don't have to even give out all the information at the same time, So yes, there is information there, but I think you need social scientists to come in to tell you when to release what, But the information be simple, clear, and understandable.
Thank you. The next question, I will put it to you, Professor Hirhoff. And so it's from Francis Menza. He asks, please, since poverty is usually an underlying factor in NTDs, are there any community elevation programs about being championed by G-WAC to help combat poverty in endemic areas of priority NTDs?
Well, not in the strict sense that we sort of bring about some relief or improve the financial situation, but I think as much as we go into these communities and do work against NTDs and against disease sequelae, improving the situation of the patients, I think that will lead to an improved life for them. And we have lots of cases where people with a better lymphedema can restart their work, can get back to the business they had. And in that, I think this is what is the very cornerstone of NTD control and fight against NTDs, that you enable the people to go back to their normal lives and take part in everyday life, including earning money and improving their situation. I think that's what we do. I think the programs are by way too small to combat poverty as a whole. That is something that the state itself has to do. But we can help finding new ways how to better treat a certain NTD, as we did with lymphedema, for example. And that's, of course, it can be spread out far beyond these communities where we have actually done the studies. And this is what we do by policy transfer, that we let the national NTD programs know what works and what would work better, and that they can spread it out. And we also accompany that by our digital health systems that I referred to.
Thank you. Just to stay on that point, you showed some slides where there are interventions like lymphedema management, where you and Professor Deborah are working together. And it has been shown that these things also help reduce the days to work lost, which is important in poverty engagement. Can you expand a bit on that?
Alex, do you want to go ahead on that?
I can go ahead.
Okay. No, I think that pretty much says, in other words, days without disease or disability adjusted life years is another term. This is something that, if done throughout the affected population, it really comes down in figures and will also be visible in those communities. But I think for us, doing a few hundred patients in studies, it still resides a lot with individual fates, and we can tell several ones. For example, the girl that really had to get the foot amputated because of a very severe elephantitis, something that should not have happened, but that was before we actually came to these communities. That we could at least help her by other funding to restart her business as a shopkeeper, and this is something that we do punctually, definitely. In that, of course, we help combat poverty and give a new perspective to people.
Thank you.
Okay, if I can add a bit to what Akin said, when it comes to the lymphedema that Professor Hirhoff presented, for the people, what bothers them is not the enlargement of the leg, but the periodic attacks that they get, when they are not able to go to farms, they are not able to go for fishing or whatever, they become bedridden and dependent. So as part of G-WAC work and take off what we are doing at the moment is actually go to these communities, give training to the nurses, the physician assistant, the community health workers, about how the people should keep their, legs clean so that they can avoid getting frequent attack. attack, and by reducing the number of attacks, they're able to go to their farm, they're able to work, and by so doing, they earn incomes, and this will reduce the poverty in the communities. Thank you.
Thank you. We stay with you, Prof. Deborah, with the next question, which is in regards to outraged groups. So if they could show the question. So they say, with regards to outraged groups, you mentioned that it's important to be tolerant and apologize when necessary. However, in the face of an extreme outraged population, how does one do the communication? How does one strike a balance between his duties of educating the public and also personal disposition to react to such attitudes?
Yes, I mentioned different kinds of audience, but in the case of the one that he's referring to, sometimes the people get agitated because of past experience. Somebody has gone there to do something, the person did not go back to give them, results. So they see you as a liar. And for the community, dwellers, they cannot differentiate between Dr. Corey and another person. For them, you are the same. Scientists are the same. So if you go there and they have a genuine reason and they are agitating, at that point, you need to actually understand them. No amount of words will convince them. And if you try to actually challenge them or, challenge them or trying to convince them, it may lead into chaos. So that's why I said, in this case, you just have to listen to them, acknowledge their concern, and if possible, apologize. You might have not, done it, but somebody did it, and that's the effect. And if you don't take care, the effect will be ripple. So you have to apologize. And you see that sometimes when you accept, what they are saying, they come down to your level and try to understand you. And in this case, you take advantage and educate them.
Thank you. I go to the next question, and the question is, there are some neglected tropical disease of animal which are zoonotic importance. For the purpose of One Health approach and goals, are the modules or pipelines planned to address the entities of zoonotic importance? Professor Hill?
Yeah, so I'm just wondering whether the question refers to what we are doing within G-WAC or rather on the WHO level. So let's start with the latter maybe. Of course, if you can actually check this in and download the WHO roadmap with the annexes. And in the annexes, there are plans for every of the 20 NTDs. And in the zoonotic, with the zoonotic diseases, the modules do plan to address the zoonotic origin. This is what was in this green slide with the second pillar. So holistic approach, not only the human medical approach, but of course a holistic approach. So for tapeworm, you have to have a veterinary plan to make sure that there are not that the load of infected pigs at least is reduced, or that the meat is looked at. That cooking can be advertised better through all kinds of social channels we have talked about. So particularly with what we are doing, we can only, with limited funds, only have a small segment of all entities we are covering. So with the filaria, which is not a zoonotic disease, this does not directly apply. So we don't do that in our work plans, but of course, as soon as the zoonotic diseases is affected on a larger level of observations or beyond G-WAC, so to speak, it must be done, sure. Yeah.
Prof. Deborah, do you want to add something?
I think Akim has answered it all.
I just asked a bit of questions. There are no more questions online, but I have a question, and you've given a very interesting example, Prof. Deborah, and that's in the importance of communication, like using on local radio stations. Sorry?
Patricia, I can't hear you.
Okay. I can hear you, but Professor Health, can you hear me?
Yes, I can hear you. Alex, can you hear again? Is there a lack of communication at your end? Can you hear us now? It seems not to be the case. There's something.
Okay, Prof. Deborah, you still cannot hear me.
Patricia, I can't hear you.
So Patricia, I can't.
Can you hear Professor Herhoff? I think he can
Yeah,
also.
I can. I'm staying. I can hear you, and I can hear Professor Deborah as well. So
I think I will write in the chat to Professor Deborah, but to you, Professor Herhoff, one thing you also mentioned that was interesting is the antimicrobial resistance. How much role does it play in emerging and re-emerging diseases?
say again, how much role?
What key role does antimicrobial resistance play in emerging and re-emerging diseases, and just general in disease combat?
I think in the sheer numbers of people infected, of people not getting the optimal treatment, particularly in high-level medicine, when you need to make sure, for example, someone operated or someone even immunosuppressed must not acquire an infectious disease. Here, antimicrobial resistance actually comes in as a limit to what medicine can practically do, if otherwise it could do more, technically. So this is one thing, and I don't know if it's this. I'm not really aware that it has been properly measured. What has been measured is the death rates, and there are of course there's also underreporting, but there is millions of people dying each year because of bacterial infections that could in principle be treated if we didn't have so much antimicrobial resistance. And this is something we need to roll out much better. We are now trying, for example, within our research projects to get an idea about resistance of bacteria in wounds, because we are working a lot with lymphedema and there's a lot of wound infection. So we can combine that and get an idea of what people in outpatients, or not in the hospital acquired wounds, actually acquire in terms of resistance. Are there resistant bacteria at all? And if yes, which ones? So does that lead to a change maybe of the recommendation? Currently, when you have acute attacks in lymphedema, you take amoxicillin, but maybe this is not enough. So we will have to see what we find. And of course, this can also be rolled out depending on project money on a larger scale. And I think what really also needs to be rolled out, for example, in Ghana, but in many other countries as well, and even also in Germany, I wouldn't make an exception here, is more diagnostics with regard to resistance. So, for example, in the outpatient sector in Germany, we don't test at all. We just give antibiotics on clinical aspects, which is not correct, basically. And of course, this is done in many other countries, and we will only get a more representative picture if we test more, and this may lead to a change of guidelines, national and international.
Thank you. Professor Deborah, can you hear me?
Okay, I cannot hear you.
Okay, thank you. So I put the next question to you, which is on risk communication. And I will combine it with the one that follows. So the two questions, so from Maxwell and from Stephen. So Maxwell asks, what are the effective ways of carrying out risk communication in the midst of conspiracy theories, and in such a way to get an information down? I think we covered that a bit with social media, but we move to the next question with Stefan, then you can combine. And Stefan asks about psychiatric patients. They're hard to convince, and how do you communicate to them without risking? So just combine the two questions, Prof. Deborah.
Yeah. Of course, as you said, psychiatric patients, they are hard to convince, they are difficult to convince, but I don't think they are hyper throughout, when they get attacked, they become, agitated, but with time they calm down. And then when they calm down, you can talk to them, So when you go to psychiatry hospital, we have experts who actually talk to them. So at that point, if the person has attacked, and you are talking to the person, you are wasting your time. You need to wait. When he or she recovers a bit, then you can actually talk to him or her. The other question is
on conspiracy theories.
Yeah, I think I've answered partly, that question. That when I mean conspiracy theorists, they are with us and they continue to be with us. And when it comes like that, I think RCC needs to come in. We need to use all kinds of media that we have, social media, going to the people, employing social scientists to actually talk to them. We saw that during the COVID-19 when there were so many conspiracy theories, and I use our president as an example. So yes, people will conspire, and propose the theories, but RCC needs to come in. We need experts, we need social scientists to actually talk to these people, go to them, talk to them in any form. Thank you.
Thank you. And the next question is to both of you, and that is, what is the collaboration or involvement of veterinarians in NTD research and risk communication, if about 50% of them are zoonotic? So we start with the professor here of involvement of veterinarians and in collaboration.
I think in the past, definitely the veterinarians have also worked and found out a lot. It's probably more recent, let's say recent 4 or 5 years, that the perception has really become more prevalent that you need to do it in a One Health approach, that you really do collaborations. And depending on how much it is propagated, there will be collaborations. For example, within G-WAC, we have the veterinary faculty as part, and of course we do joint projects because we see the mutual benefits. And this short course is on One Health. This also reflects that we are recognizing that we need to really close this gap. And also in Germany, there is a lot now more funding for One Health aspects, and usually the entry card into a project funding, one of the minimum requirements is that you have both disciplines on board, veterinary and medicine, and ideally another one as well. So I think as we see the future coming, there will be a lot of One Health projects, and they always, with regard to zoonotic diseases, will if they are to succeed and to bring in money and really to be approved, they will have veterinary and a human medicine component.
Thank you, Prof. Deborah.
Yes, I think veterinarians are very, very important when it comes to risk communication and pandemic preparedness. As the person rightly said, about 50% of these zoonotic diseases in this, pandemics, are contracted from zoonosis, And when it comes to our setting, the way we slaughter our animals, in the houses, the way people like bushmeat, killing all kinds of bushmeat, and then you just travel on the way from Kumasi to Accra, you see a lot of, bushmeat around. As to how they were, slaughtered, nobody knows, This is where we need to come in to actually educate them on the proper way of, handling the samples, proper way of, So a veterinarian, involvement is very, very important. We need to work together with them. The butchers, sometimes, when they bring the animals to abattoir, they are about to die, sometimes they just slaughter them, without knowing what is actually wrong with the animal, or that they know the animal is sick. Let me kill it before it dies, because if it dies, nobody will buy. And then they kill it and then they sell it. So we need to actually involve veterinarians in RCC and pandemic preparedness.
Thank you very much. And I would just want to add that there is a YouTube video link, and you can watch it to see some of the questions that I've already, some questions that are like the risk communication. You can watch it in the video. Professor Deborah has presented that on his presentation. And so just access the YouTube link and you can read some of the questions, and we don't have to repeat that. And also the issue of myth and miscommunication, I think Prophet Deborah and Professor Health have covered both of those questions on their address on social media, on their address in addressing different groups, and also on conspiracy theories. I think we are coming to a close, and first of all, I would really, really want to extend my appreciation to the G-WAC community, so the Pandemic Center, for organizing this very nice sessions. And I want to thank you, Professor Hill, for taking the time to be here, and also Professor Deborah for taking the time to be here for the presentation and for answering the question. And I really want to thank all the participants. So we've had a very big turnout. I think the last time I saw it was more than 120 people online on YouTube, but I think we had a lot of people, and I've been told by the moderator to first of all wish everyone a happy International Women's Day. So to all the women listening, including myself, happy Women's Day. And I would like to also announce tomorrow's presentation. And those of you who've been asking questions on veterinarians, we will have Professor Emipke, who is the Dean of Veterinary Medicine, and also, as Professor Hirf has mentioned, about Professor Christian Droston. He will also present tomorrow. So I'm really excited for tomorrow's session, and I'm really excited to having had such a big audience and enjoying such a session. Thank you very much. Thank you to the G-WAC, and also to the funders. There is a question I don't know whether we should take, but I've been told to close. One more question. Okay, I'm allowed to do one more question, then I can close. Okay, so we have one more question. And what have we learned in mass communication in COVID pandemic that we can employ in the next pandemic? So just put that with the closing remarks. So we start with you, Prof. Deborah, and then Professor Health can close with his closing remarks.
Okay, so what have we learned in mass communication in the COVID pandemic that we can employ in the next pandemic? Yes, I think for the COVID pandemic, we learned a lot. We saw that our, televisions were flooded with adverts, all kinds of adverts. We should wear nose masks, hygiene. I've been telling, my students that if not for anything, COVID has actually brought, personal hygiene, because people have learned how to wash their hands, And again, this happened, about 4 or 5 years ago in Liberia when Ebola broke out, because of the strange hygiene, practice. NTD, or intestinal infection, actually reduced from 98% up to somewhere 5%. It's because of the mass communication about hygiene. And so for this COVID, we've learned a lot, about hygiene, about social distancing, about, at least for one thing, for now when you go to funeral in Ghana, we don't shake hands like we used to do, and I think this is very, very important, because before COVID, it would have been difficult for us to actually not greet somebody or shake hands with somebody during funeral. But because of, COVID, now when you go to your attend funeral, you don't, shake hands with anybody, which I think is a good, practice as far as, transmission of infection is, concerned.
Yeah, I think I can just continue from there. Very similar also in Germany. I think we very much reduced the handshake in formal greetings. I always, before, when traveling through Asia, I watched the Asians, the Thais or the Japanese doing this for a greeting instead of shaking hands. And sometimes I practiced that even before Corona, when there was like a wave of cold or influenza and we had to sit together with our boards in a 20-person meeting. And I said, okay, I'd rather do it the Asian way so that we don't infect ourselves. So that was something. I think this will probably stay. A much higher awareness for hygiene, so we don't have to start from scratch. Probably I would expect that Professor Drosten tomorrow will also tell you and say the next pandemic will be completely different to what we expect. And that's possible. I mean, we could expect something from the influenza species area, swine or whatever influenza, that has a little bit of different transmission properties. Another coronavirus, just like this one, could also arise from another animal species that is being used in the industry very much. For this, really, it would be important to know whether it really was that source of animals or whether it was a lab accident, which can never be fully excluded. It's unlikely, but this is what you also will hear from the corona experts. But if we knew that, we could at least gauge it a bit better how likely the next corona pandemic is. It's definitely not to be excluded that we see it from another species and as different as SARS-CoV-1 was from SARS-CoV-2, and maybe a SARS-CoV-3 again different with no population immunity. But then at least I think we could employ a lot of what we have learned from SARS-CoV-2 to a SARS-CoV-3 pandemic. But if we have a different virus with a completely different transmission, like fecal, oral, whatsoever, then we really have to employ our new measures and try to bring them over in the way Professor Deborah has taught us, in a manner that is not overcomplicated and is also listening to dissenting views and trying to bring everyone on board, and in the beginning gauging the different levels of attention and outrage. I think this is a very interesting concept that makes a lot of sense. In that respect, I hope everyone has learned from this afternoon. I did a lot, and I'm also happy that this is definitely something that also relates to the last question. What has Corona brought about? Think about pre-Corona days. We probably wouldn't have had this type of session with lectures over 2 continents. And I would like to see this become more frequent, become more usual. We are doing in Germany, for example, a new lecture, a nationwide lecture in German on tropical medicine, because we see that the faculties are too specialized to hold for all tropical medicines in all universities. So we are taking advantage of that, and I think for tropical diseases and pandemic prevention, we should actually bring this even to a larger scale. As you may know, there are several such pandemic centers, 4 funded by Germany, and I'm sure there are many others. And of course, you could do more webinars and also do for example, link with the pandemic prevention people in Latin America and others. Bring that together. I think it can help save resources and broaden the horizon. So in that respect, I think we continue even without the next pandemic to be more virtual, have larger audiences, and educate ourselves mutually more effectively. Thank you very much.
Thank you very much, and thank you everyone so much. And just to be updated, the G-WAC organizes a lot of talks and has a lot of things on offer for student exchange. So you can visit our website at gwacmind.org. That is gwsc.org. And with that, on behalf of the G-WAC team, and with a special thanks to all of you and the organizers, I think we have come to the conclusion of the day. Thank you. Good night.
Good night.
Good night.